students, welcome back to my YouTube channel. I am Dr. Pooja Bansal and this is my 15th video. As you know, I am discussing some practical topics in OBS and Gynae. Today I'll talk about intrapartum fetal monitoring, but particularly emphasizing on cardiotocography. So what is intrapartum fetal monitoring? It is monitoring of fetus during the labor, can be done by intermittent fetal heart rate auscultation or electronic fetal monitoring, that is cardiotocography. Intermittent fetal heart rate auscultation is done by stethoscope or handheld Doppler. It is indicated in low risk pregnancies. Its frequency are as follows. In latent phase, it is heard every 60 and 30 minutes in low and high risk pregnancies respectively. In active stage, it is heard every 30 and 15 minutes, and in second stage of labor, it is heard every 15 and 5 minutes. It is heard on the spino-umbilical line of the maternal abdomen where the anterior shoulder of the fetus is present. But we have to remember one thing, it is heard after the contraction goes off, not in between the contraction or not during the contractions. And it is heard for full 1 minute. For example, in cephalic presentation, when the back is anterior, it is heard on the spino-umbilical line somewhat here. And the back is posterior, it is heard towards the flanks of the abdomen. In breech presentation, it is heard around the umbilicus of the mother. Let's discuss our main topic, that is cardiotocography, also called as electronic fetal monitoring, which is based on the Doppler principle. Cardio is for fetal heart, toco is uterine pressure and a graph. And I am sure you must have seen this CTG machine in our labor room. So this is monitor. In upper part it is showing fetal heart rate and in lower part it is showing uterine contractions. And this is CTG paper running at the speed of 1 centimeter per minute. And there are 3 different type of probes, actually 4 probes. One is fetal movement probe, and this is held by the mother, and button is pressed when the fetal movement is felt. And there are 2 cardio probes placed on the spino-umbilical line of the mother, and it shows fetal heart rate. And third type is toco probe placed on the mother fundus, measuring intrauterine pressure. Cardiotocography is indicated in high risk pregnancies. Maternal indications are preeclampsia, diabetes, antepartum hemorrhage, or any maternal disease like cardiac, renal, or liver disease. Intrapartum indications are previous cesarean, premature rupture of membrane, chorioamnionitis, and induced labor. Fetal indications are intrauterine growth retardation, premature baby, or multiple pregnancies, oligohydramnios, breech presentation. Intrapartum conditions of fetus are meconium stained labor and abnormal fetal heart rate. Let's discuss about the procedure. First, we have to mention the date and details of the patient. Then patient is asked to lie down in the semi-fowler position with empty bladder like this. So, what is the difference between the non-stress test and CTG? Non-stress test is done during the antepartum period, mostly after 28 weeks of gestation. It is called non-stress because it is not done in labor or stressful conditions. It is done weekly in low risk pregnancies and bi-weekly in high risk pregnancy. It is of 20-minute trace, and if it comes up normal, then 40-minute trace is done. It assesses the acute condition of the fetus. This is the example of NST, that is, we have to measure baseline fetal heart rate, beat to beat variability, and fetal heart rate accelerations. On the other hand, CTG is done during the intrapartum period when patient is in labor, and it is a continuous trace, and it assess acute and chronic condition of the fetus and along with the baseline fetal heart rate, beat to beat variability and acceleration, deaccelerations are also seen. Let's discuss about the CTG paper. It runs at the speed of 1 centimeter per minute. On the upper part on y-axis it shows fetal heart rate, and on the lower part on the y-axis it shows uterine contractions. On the x-axis it shows time in the seconds. And in this CTG, every sixth horizontal line and vertical line is bold. And let's zoom this one big square, and it measures 60 seconds on x-axis and 60 beats per minute on the y-axis. And this one big square contains 36 small square. Small square measure 10 seconds on the y-axis and 10 beats per minute on the 10 seconds on the x-axis and 10 beats per minute on the y-axis. So let's discuss about the interpretation of CTG. This can be remembered by a mnemonic, Dr. C. Bravado. D is for defining the risk, if either the patient is low or high risk. C is for contractions. Normal contractions are 3 contractions in 10 minutes and each contraction lasting for 45 seconds. And high contractions are when there are more than 5 contractions in the 10 minutes. BRA is for baseline fetal heart rate. Normal baseline fetal heart rate is 110 to 160 beats per minute. For example, in the CTG, baseline fetal heart rate is 150 beats per minute. What is bradycardia? When fetal heart rate lies between 100 to 109 beats per minute. There are certain conditions which can lead to bradycardia. Examples: congenital heart block, maternal hypothermia, when periodization is more than 40 weeks and mother is on benzodiazepines. Tachycardia, when the fetal heart rate lies between 161 to 180 beats per minute. It occurs during the fetal infection. Maternal infection like chorioamnitis, which is most common indication, and periodization is less than 32 weeks, or if the mother is on atropine or terbutaline. There is another pattern known as sinusoidal or sine wave pattern. It occurs during the fetal anemia. Indication leading to fetal anemia: RH incompatibility, twin-to-twin transfusion syndrome, and vasa previa. In all these conditions, there is destruction of fetal RBCs which can lead to fetal anemia. Second is fetal hypoxia, which can occur during the umbilical cord compressions, or third is if mother is on analgesics. C. This is sinusoidal wave pattern. In this you can see fetal heart rate lies between 120 to 160 beats per minute. There is decreased variability or there is absent variability, and there are no acceleration. Therefore, it is called a sine wave pattern, as it is forming a wave-like pattern. Then V is for variability, beat to beat variability. Normal it is 5 to 25 beats per minute. Variability means variation of heart rate above and below the baseline. It signifies that autonomic nervous system of fetus is working very well. What is decreased beat to beat variability? When there is less than 5 beats per minute, variability is there. What is the mechanism behind this? It occurs in fetal hypoxia, which lead to fetal acidosis, leading to activation of fetal brain chemoreceptors, which affects the variability. There are certain causes. For physiological causes are when fetus is sleeping, but fetus never sleep for more than 90 minutes, in premature babies, or if mother is on sedation or corticosteroids. There are some pathological conditions also, like fetal hypoxia, fetal brain hemorrhage, and fetal infections. And one most important thing is, it is a single most reliable sign of fetal compromise among every other sign. Then BRAV. A is for accelerations. Accelerations occur in response to fetal movement. Normal acceleration or reactive NST is said when there are two accelerations of more than equal to 15 beats per minute of more than equal to 15 seconds. This is said to be reactive NST. And if period gestation is less than 32 weeks, reactive NST is said when there is more than equal to one acceleration of more than equal to 10 beats per minute of more than equal to 10 seconds. Then D is for deceleration. Sudden fall of fetal heart rate of more than 15 beats per minute for more than 15 seconds. There are three types of decelerations. First one is early, known as type 1 dips. It is also called as mirror image. For example, when the uterine contractions start, fetal heart rate start dipping, and during the peak of the uterine contraction, fetal heart rate is lowest. When the contractions subside, fetal heart rate return back to normal. This is a CTG showing the early or type 1 dips. It occurs during the fetal head compression, which occur during the second stage of labor due to vagal stimulation, leading to activation of parasympathetic nervous system, and there is deceleration. There is no need of management because these are normal decelerations. Second is late deceleration or type 2 dips. See, in this picture, when uterine contractions start, fetal heart rate is normal. When there is peak of uterine contraction, then fetal heart rate start dipping. And after the uterine contraction subsided, fetal heart rate is still at the lowest point and it will return back to normal after some time. So there is late deceleration occurring in uteroplacental insufficiency or fetal hypoxia. Conditions leading to uteroplacental insufficiency are maternal hypertension, that is preeclampsia or hypotension, and excessive uterine contractions or intrauterine growth retardation. Mechanism behind the late deceleration is if there is uteroplacental insufficiency leading to fetal hypoxia, leading to chemoreceptor and sympathetic activation, leading to increase in the blood pressure, activating baroreceptor, and leading to parasympathetic activation will lead to late deceleration. Then third type is variable deceleration. Variable itself tells us that there is no correlation between the fetal heart rate and uterine contraction. It occurs in umbilical cord compression, and the conditions which are high risk for the umbilical cord compression are oligohydramnios, postpartum pregnancies, and malpresentation. And bravado, O is for overall impression and management. Normal or reassuring CTG is said when baseline fetal heart rate lies between 110 to 160 beats per minute, variability is 5 to 25 beats per minute, and there are acceleration present with no deceleration, and these are normal, so no action is required. Suspicious or non-reassuring CTG is said when bradycardia is there, when example 100 to 109 beats per minute, or tachycardia of 161 to 180 beats per minute is there, and variability is less than 5 beats per minute but for 40 to 90 minutes. There are no acceleration or early deceleration or typical variable deceleration or one prolonged deceleration up to 3 minutes is there. Pathological or abnormal CTG is said when bradycardia is there of less than 100 beats per minute and tachycardia of more than 160 beats per minute is there, or sinusoidal wave or sine wave pattern is there, and when there is less than 5 beats per minute variability for more than 90 minutes with no acceleration and There can be late deacceleration, atypical variable deacceleration, or one prolonged deacceleration of more than 3 minutes. In both suspicious and pathological, vigilant assessment is done. Mother is asked to lie in the left lateral position, and we have to administer 4 to 8 liters of oxygen and check the vital of the patient. We have to stop the oxytocin infusion and IV fluids are started. Artificial rupture of membrane is done to rule out any meconium stained labor, and delivery is considered if persistent CTG is showing suspicious or abnormal CTG. We have to assess the station. If it is more than or equal to +2, then forceps or vacuum delivery can be considered, and if station is less than +2, then cesarean is done. According to the NICE guidelines, normal category is when all 4 features fall into the reassuring category, and suspicious is when one of the features fall into non-reassuring category, and pathological when 2 or more non-reassuring categories or 1 or more abnormal category is there. So what is the advantage of the CTG? It is shown that it leads to decrease in the risk of neonatal seizures, and it can act as permanent record for the MLC purposes. But there are certain disadvantages also. It is leading to increase the risk of cesarean sections, and there is no decrease in the risk of cerebral palsy or perinatal morbidity. Let's discuss some examples. This is a CTG. See, this is baseline fetal heart rate. Here the baseline fetal heart rate is 130 beats per minute, and beat to beat variability is very good. There are 3 accelerations present and no deacceleration is there. So this is a normal CTG trace. This trace, we have to identify the type of deacceleration. As you can see, this is showing early or type 1 dips which occurs during the fetal heart rate, fetal head compression, and it will activate vagal receptors, decrease in the fetal heart rate, and when contractions over, compression is relieved and fetal heart rate returns to normal. Identify this type of deacceleration. So this is late deacceleration or type 2 dips, and as I have already told you, it occurs in uteroplacental insufficiency or fetal hypoxia. This is a CTG showing variable deacceleration, as there are no relation of the fetal dips with the uterine contraction and is seen with the cord compression. This is a sinusoidal pattern, occurs in certain fetal anemia or severe fetal hypoxia. So guys, this was my lecture on CTG. Hope you like my video, and please do hit the bell icon and subscribe my channel. Thank you so much.